Thank you, Chairman, for a very kind introduction. And I would like to thank the organizing committee, Harry and Adam, for inviting me to talk on this very special topic. Latest updates on novel biomarkers in HBV Cure. And in fact, we had a bit of discussion in the last section on biomarkers. So I hope with my presentation, we will, increase our awareness or discussion on the biomarkers in hepatitis B, particularly in the field of now using many novel antiviral agents. So here is my disclosures. So in the blood of chronic hepatitis B patients, we can measure several virus-producing biomarkers in the circulation. The conventional one includes surface antigen, E antigen, and also HBV DNA. When we talk about novel markers, we are usually referring to HBV genomic RNA in the blood and also core-related antigen. What are the detectability rates of these biomarkers, RNA and core-related antigen, in treatment-naive and nucleoside-treated patients? And this is a summary table looking at the detectability rate of these two markers in general for two groups of patients. For example, when you look at patients who are treatment naive, if they are E antigen positive, usually we can detect both in 100% of these patients. And then when we look at patients who are treatment naive, E negative, in general, obviously depending on the assay sensitivity of the RNA and the core-related antigen. So in general, for chronic infection, E-negative treatment-naive patients, we are talking about 70% detectability rate. And for chronic hepatitis patient, we are talking about 90 to 97%. However, when we look at the NUC-treated patient who had achieved undetectable DNA, it seems that the RNA assay had increased or higher detectability rate or over 2 years of treatment compared to the core-related antigen. If we are talking about RNA, we expect to have a detectable values or level at around 70 to 80%, whereas in core-related antigen, particularly the conventional assay, the first assay, we are only talking about 30 to 48% detectability rate. So it limits our applicability, the applicability of this assay according to different groups of patients. In fact, both the RNA and core-related antigen follows a very similar pattern of levels of the conventional assay, conventional biomarkers. For example, in E-positive chronic infection, all the markers were very high, including the genomic RNA, the core-related antigen, and then the markers, the level seems to be a little bit lower in E-positive infection, and usually drop down quite significantly in E-negative chronic infection for all the markers. But if the patients have E-negative hepatitis, the levels of all these markers increased again. Not until they reach the state of surface antigen zero clearance, where all the markers become very low. And in fact, when you use the current assay to measure the core-related antigen or RNA, according to this particular study, we can only detect 18% positive rate in this very special group of patients, which is very relevant to us when we are talking about functional cure nowadays. This is a study done in my center some time ago, in fact, looking at the detectability rate or levels of the core-related antigen and also the linearized surface antigen, which has a 10-fold more sensitive level than the conventional surface antigen. And when we look at patients with surface antigen zero clearance, 21% of them, they had a detectable core-related antigen after losing the surface. When you look at the green, the blue and the red proportion, it means that the detectability of core-related antigen in patients who lost surface antigen was comparable regardless of whether these patients have anti-HBs positive or negative. However, if you look at the bars next to the COVID antigen, this is the assay we used with a 10-fold sensitivity than the conventional surface antigen assay, we can still detect 26% positive rate. But then, when you look at the distribution of this 26%, we find that if the patients who had anti-HBs positive, these patients have a very low rate of detectability. Even we use a 10-fold more sensitive assay to measure the surface antigen. In the same study, we actually have some longitudinal sample after the patients who lost the surface antigen. The dots actually showed the individual level of the COVID antigen after the years of losing the surface antigen. And you can see there were some patients, they still have detectable or measurable COVID antigen even after 4 years or 8 years of losing the surface antigen. And one patient actually, we can still detect the COVID antigen many, many years after he lost the surface antigen. Because of the importance of measuring this COVID antigen, people are trying to refine or to improve the assay. The one that I presented to you, the result I presented to you, belongs to the assay they used to record G COVID antigen using the Pneumo-Pulse G machine. And what they did in that particular assay, the first generation, is to denature the core-related proteins using a detergent they call Triton. The lower limit of quantification for this particular assay, the first generation, was quoted at 3 logs unit per ml. And then now they developed a second generation of new modified core-related antigen assay called ITAC, referring to immunoassay for total antigen, including complex via pre-treatment. What they did is they add a pre-treatment procedure by adding acid and also reducing agent urea to disrupt the disulfide bonds. Obviously, I'm not the technical person, but this is what they did to improve the sensitivity of the assay. And according to them, this modified ITAC assay has a sensitivity improved to 2.1 log unit per ml. Graphically, this is the procedure they did for the first generation, the G correlated antigen assay. And what they did is to use this detergent to manage or to deal with all this antigen and then create, dissociate this one, but still with the disulfide bond intact. And then they measure by the usual way to get a signal for detection. As I said, this assay has a lower limit of quantification of 3 logs unit per ml. The second generation, the updated or modified ITAC assay, in addition of adding this detergent, they add the acid together with urea. By doing so, the disulfide bond actually gets disrupted, and then they can measure the biomarkers with a higher sensitivity of 2.1 log unit per ml. So this is the new assay they developed recently. Using the old assay, the G assay, they actually, according to our study, we measured, we detect around 21% of patients who lost a surface antigen. However, when we use the updated one or the modified one, it can actually increase the detection rate to around 67%. And in particular, this is a diagram showing you the details of this assay, modified assay, to measure the surface antigen, the COVID antigen, as well as the surface antigen in patients who lost a surface antigen. Applying the same hypothesis, they actually, it has an improved assay of surface to measure the surface antigen, which is 100-fold more sensitive than the conventional one. So if you look at the absolute level where they can detect for the surface antigen is 0.0005 RU per ml. But then when we look at the performance or the detectability rate of these two assays, the ITAC COVID antigen and ITAC surface antigen in patients who lost the surface antigen after several years, then you can see the COVID antigen, the modified, the ITAC COVID antigen can measure around 65% all over from the time of surface antigen loss to 10 years of follow-up. Whereas, when we look at the ITAC surface antigen assay, while they actually showed an increasing proportion of patients with anti-HBs, but there will be a corresponding decrease in the detectability rate of the ITAC surface antigen assay. So meaning that if you follow the patients long enough, although the ITAC surface antigen assay with a 100% more sensitive level than the conventional one, you only expect to have 20% detectable rate after 10 years of surface antigen loss. But then the COVID antigen assay actually remains to be a very static or level, the detection rate all over the years. I will finish by sharing with you some of the data of COVID antigen and RNA under the treatment effects. By first showing you the effects of nucleoside analogs and then some low-vol agents. So this is the study in our center measuring the DNA, the COVID antigen, and the RNAs over 2 years of treatment. As expected, the HBV DNA drops profoundly after 1 year and 2 years of nucleoside analog therapy. And then for COVID antigen, it also drops from the start to year 1 and year 2. And when you look at the RNA, the median level also drops. We can see that if we treat the patients with nucleoside analogs, the COVID antigen and also p-genomic RNA levels in the blood will also drop significantly over 1 year and 2 years of time. When we compare whether there is a differential level of reduction between the tenofovir-based therapy versus entecavir-based therapy for E-positive patients, and also for E-negative, this is a E-positive patients, and this is a E-negative patients, we didn't see any difference in terms of the magnitude of reduction of the COVID antigen between tenofovir-based versus entecavir-based therapy over 2 years. And in fact, we have the data looking at the relatively longer term of entecavir treatment on COVID antigen, and you can see that there was a continuous decrease in the COVID antigen over time during these 7 years of therapy of entecavir, and the median reduction over 7 years was around 2.2 Ku per ml in this particular cohorts. And early on, there was a study looking at the reduction of the RNAs after entecavir treatment for 1 year, and you can see that after 1 year of therapy, the RNA also dropped in entecavir group of patients. And we also extend the treatment to 2 years, and after 2 years of entecavir treatment, not only entecavir is actually entecavir or tenofovir-based treatment, we find that there was a continued reduction from at 1 year 1.5 logs and 2 years 1.8 logs reduction from baseline during the Lux therapy. And when we look at the result at 2 years, we find that although there was a good drop of the RNAs after 2 years, using the assay with a limit of detection of around 45 units per ml, we can still see 78% of these patients after 2 years of entecavir treatment or tenofovir treatment still have a measurable or quantifiable HBV RNAs. It indicates that we can still measure the RNA levels in many of our patients even after taking 2 years of nucleoside analog therapy. This slide actually I already mentioned, but what I want to show you is that we find that the magnitude of reduction in terms of log reduction for both COVID antigen and RNA were very similar. You can see after 1 year or 2 years, the magnitude for these biomarkers were very similar to each other. So how about the newer antiviral agents' effect on these biomarkers? This is a BEPI presented I think 2 to 3 years ago, and with the higher dose, the 300 milligrams, we find that there was a reduction, obviously for the surface antigen, but there was also reduction in the COVID antigen and the RNAs, and mainly happening in the E negative patients rather than in the E positive patients. sRNA LG6346, again you can see a reduction of the COVID antigen after 4 doses of sRNA, and the reduction of at least the median level was kept quite, statically after even 1 year or 2 years of therapy of this sRNA. Very similar findings were observed for HBV RNA, and the effect seems to be very sustainable even after stopping of this sRNA. Very similar findings in another sRNA 3989. You can see that patients had a very profound surface antigen reduction after 3 doses, but then you can also see the COVID antigen and including the E antigen, the COVID antigen, and also the RNA has a very profound reduction after being treated with 3 doses of this sRNA. And again, you can see the sustainability of this reduction after the drug was being discontinued in the trial. And furthermore, if you classify or stratify patients with different different responses in terms of the surface antigen reduction, for those who had sustained surface antigen response, defined as greater than 1 log reduction during the period of follow-up day 0 to day 392. For those who have sustained response, you can find all the antigens reduction was better than those who cannot have the sustained or no response to the sRNA. Meaning that if a patient are responding to the in terms of surface antigen reduction, you would expect these patients had the best reduction of the E antigen, COVID antigen, as well as the RNA. Another sRNA, VR2218, showing you the same thing, E antigen, COVID antigen, and RNA. And this study also showed that the reduction of this COVID antigen and also RNA in the E positive patients was dose dependent. So with a lower dose, the reduction may be less. With a higher dose, depicted in orange lines, you can appreciate the greater reduction of the RNA and E antigen as well as the COVID antigens. Last sRNA 729, either given in a single dose or repeating dose, you can see some patients actually have a very profound reduction of RNA and some reduction in the COVID antigen. And in fact, although this number was small, there were many patients, several patients who had the achieved undetectable or target not detectable RNAs after a single dose or repeating dosing of this particular sRNA. This is an early study looking at the relatively more long-term effect of the antigens but in patients who received nucleoside therapy plus Repicovir, the first generation CPAM. And this is a very granular data showing you that the E antigen, the genomic RNA levels, and also COVID antigen did have reduction, dropped in this particular E positive cohorts. But then you can argue whether this is related to the nucleoside analogs, because these patients have nucleoside analogs together. And I have already shown you nucleoside analog itself can be associated with the reduction of COVID antigen and genomic RNA. So I would like to end by recommending you to look at this late breaker's poster in this meeting, where using a second gen or a newer capsid inhibitor will have any reduction of the COVID antigen and RNA. And in this particular study, we had a group of patients who were just receiving the mono COVID antigen in this particular study. So that you will see the response is actually quite good in terms of the COVID antigen reduction and RNA, even without the addition of nucleoside analogs. So my conclusions are COVID antigen and RNA are easily measurable in the blood of our patients. The cccDNA transcription activity may be represented serologically by COVID antigen and RNA, whereas the surface antigen can be generated from the cccDNA and integrated DNA. The ITAC version of COVID antigen has a better detection rate in patients with surface antigen seroclearance. It seems that the HBV RNA has a better detection rate in the NUC-suppressed patients compared to COVID antigen. Both can serve as a biomarkers for target engagements in novel antiviral agents with different modes of action. We really want to know whether combining these two assays can improve the disease prediction, prognostication, treatment responses in chronic hepatitis B cure. Thank you for your attention.